The following podcast is part of a certified educational activity titled Time-Limited Innovation for CLL Control, Changing the Treatment Story with Evidence and Emerging Consensus on First-Line BTKi BCL2i Combinations. Access the entire activity and complete the post-test at peerview.com/RMQ860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Nitin Jain from the MD Anderson Cancer Center. Welcome to this microlearning program on the expanding role of time-limited therapy with BTK and BCL2 inhibitor combination in CLL. The goals of this program will be to improve your understanding of the guidelines updates which have occurred recently on time-limited treatment regimens, including the combinations of BTK and BCL2 in treatment-naive CLL, to increase your understanding of the evidence supporting this time-limited approach of BTK and BCL2 combinations, and then to provide you the skills to select and safely deliver treatments of this time-limited BTK-BCL2 combination approaches. We'll achieve these goals through a series of educational modules on time-limited therapy in CLL, designed to explore current guidelines, evidence, and practical aspects of care with BTK-BCL2 combinations through a series of questions and then short supporting lectures. So let's begin. So you've just answered a question about how time-limited therapy with target regimens are reflected in the current guidelines. So let's take a look where we stand in 2025. So if you look at the NCCN guidelines for first-line therapy for patients without deletion 17p or TP53 mutation, currently there are several preferred approaches. One preferred approach, namely venetoclax plus obinutuzumab, has been there in the guidelines for a while, supported by the CLL14 study. So that's a 1-year time-limited approach of venetoclax coupled with 6 months of obinutuzumab. Then we also have a recently added category 1 indication of venetoclax plus acalabrutinib with and without obinutuzumab. This is based on a trial presented at the ASH meeting last year and recently reported in New England Journal. The trial is called the AMPLIFY study, and we'll talk about that in the next slides. So these are the two time-limited approaches which are recommended per the NCCN guidelines, again, namely venetoclax obinutuzumab or venetoclax plus acalabrutinib with and without obinutuzumab. We also have covalent BTK inhibitor therapies, which have been in the guidelines for a while. These are continuous oral daily therapy, which includes acalabrutinib with and without obinutuzumab, or zanubrutinib monotherapy. And I should also mention, as you see, there are other recommended regimens, namely based with ibrutinib-based therapy, so ibrutinib monotherapy, and also ibrutinib plus venetoclax, which is not approved in the United States by the FDA, but is approved elsewhere. But the preferred regimens, as we discussed, are namely 4 regimens. As you can see, 2 are time-limited approaches for 1 year, and 2 are long-term BTK continuous therapy. Now, if you look at the recommendations, again, for the first-line therapy, but for a patient with deletion 17p and or P53 mutation, we pretty much have a similar recommendations. Again, 1-year time-limited therapy of venetoclax plus obinutuzumab is recommended, as well as venetoclax acalabrutinib plus and minus obinutuzumab. Now, you could ask a question that in the AMPLIFY study, this particular patient population was not studied. So AMPLIFY study excluded patients who are deletion 17p or P53 mutation. However, I believe the NCCN Guidelines Committee felt that given the other data we know for 17p deleted patients, including data with a triplet combination of acala, obin, and venetoclax from the Dana-Farber group, and some other BTKi-ven combination data for 17p patients, it was appropriate to include this regimen. And again, we have covalent BTK inhibitors, namely acalabrutinib and zanubrutinib, which are continuous daily therapy. I should mention that some guidelines do recommend for 17p P53 patients to be on a continuous long-term BTK inhibitor therapy, as at least the PFS with ven obinutuzumab, 1 year of ven obinutuzumab, where we have data for 17p patients, was somewhat suboptimal long-term. Among the other recommended regimens, still we have ibrutinib, and we also have ibrutinib plus venetoclax. Now, what about the European guidelines? So this is a summary paper from the ESMO guidelines. Again, talking about CLL patients in early stage disease or advanced stage disease and how to manage them and recommended regimens based on IGHV status, as well as with P53 and deletion 17p. Again, the guideline are pretty similar to the US-based NCCN guidelines. There is more mention of venetoclax plus ibrutinib here because that regimen is approved in Europe for patients with CLL. Here, the guidelines also have a recommendation, and that is also a recommendation still in the NCCN guidelines of chemotherapy for FCR IGHV mutated patients. Though I would say, from if you have access to novel therapies, chemoimmunotherapy should not be used. So currently, both venetoclax or venetoclax and ibrutinib plus venetoclax are time-limited options available in the EU, and eventually we'll have to see based on the amplified data when acala-ven plus minus obinutuzumab gets added as well. For P53 patients in these guidelines from Europe, again, very of the same approaches we saw before: continuous BTK inhibitor therapy, venetoclax monotherapy in the first-line setting, combination of ibrutinib venetoclax obinutuzumab, and also idelalisib plus rituximab is recommended as well. But I would say that probably in the first-line setting, we should stay away from it because of the risk of immune complications. So hopefully, as you saw, I think this kind of nicely summarizes the frontline regimens for patients, both from the NCCN standpoint in US as well as from the European guidelines. Let's find out more about the initial clinical experience that was reported with the fixed duration of BTK and venetoclax combinations. So several years ago, I would say this dates back to just about 10, 12 years ago, as both BTK inhibitor, and at that time was really ibrutinib, and BCL2 inhibitor, again, venetoclax, were coming along in the context of CLL. One obvious question was, can you combine these drugs together? And at that time, many groups, including our group, were looking at these combinations in the preclinical work in the lab, and there were several arguments to combine the two together. There was a preclinical work which supported the synergy of the two, but also from a clinical standpoint, we knew that ibrutinib works very well on the lymph node tumor burden. It decreased the lymph nodes very well, but ibrutinib does not hit the bone marrow very well. Patients will still have residual disease in the bone marrow if you treat them with BTK inhibitor alone therapy. On the flip side, venetoclax clears the blood and bone marrow very, very well, and really patients get to MRD negative remission when they receive venetoclax. And their toxicities were also not overlapping. Ibrutinib has these BTK side effect toxicities, skin rash and hypertension and atrial fibrillation, and venetoclax is more associated with neutropenia, tumor lysis syndrome. So we and many other groups felt that it was safe to combine these regimens together. And then many of the studies were started looking at these combination approaches. One of the first studies in this regard was from our group at MD Anderson, where we combined ibrutinib plus venetoclax together, but we used an approach of 2 years of combination therapy, so 24 cycles. So patients had a lead-in of 3 months of ibrutinib, and then the venetoclax was added. And then both drugs were continued together for a total of 24 cycles. And in fact, in the study, we had a provision of continuing a 3rd year of ibrutinib plus venetoclax for patients who still have MRD positive disease by flow cytometry in the bone marrow. In this study, we treated 120 patients at MD Anderson. As you can see, these were high-risk genomics patients because we purposely selected high-risk patients for the study. And as you can see, the 5-year PFS, which we reported at the ASH meeting a couple of years ago, was just around 90%. So, and then overall, 52% of the patients achieved bone marrow undetectable MRD remission. It was at 1 year mark, but when you look at overall as a best response, that was close to about 70%. So a kind of a very effective approach without a CD20 antibody to get patients to MRD negative remission. At the same time, a larger study, multi-center international study was planned, which was called the Captivate study, kind of using a similar philosophy, a similar theme, I guess I should say. They also used 3 cycles of ibrutinib lead-in And then they use, instead of 2 years of combination, they use 12 cycles. So 1 year of combination of ibrutinib plus venetoclax. And there were a couple of different arms in the study. There was a fixed duration cohort, but also there was an MRD guided cohort where you can get additional therapy based on MRD at 1 year mark. This study has been updated several times, and this was the last update where they had 159 patients. You can see here the genomic subgroups is typical of what you would expect in a frontline patient population. If you look at all comers, the 5-year PFS was 67%. Now, this is maybe numerically lower compared to an MD Anderson study, and that could be in part because of 1 year of therapy here as opposed to 2 years we did in the MD Anderson study. There was also an updated analysis presented at the ASH meeting by my colleague Bill Vieda, where they looked at bulky adenopathy specifically and tried to see if that correlated with the outcome. And it looks like patients who had bulky lymph nodes, they were kind of doing well as well. And then in terms of the registration study for this ibrutinib plus venetoclax, the study which led to the approval of ibrutinib plus venetoclax outside of the US was the GLOW study, which was a randomized study comparing ibrutinib plus venetoclax, again for 1 year duration, versus chlorambucil obinutuzumab, which was kind of, a de facto standard of care some years ago when the study was designed. And as you can see from the PFS curves which are shown, clearly ibrutinib plus venetoclax is outperforming chlorambucil obinutuzumab. And this led to the approval of this regimen outside of the United States. Here again, you can see if you were to see this 5.5-year PFS, which is listed on the slide, it's about 52%. So maybe not as good as the MD Anderson study. Also, one other important study to mention here is a FLAIR study from the UK, which actually used even longer duration of treatment. They used up to 2 to 6 years of therapy based on MRD guidance, and there were some criteria, how do you do the MRD guidance? And there, they have reported 3-year data. 3-year PFS was like 97%. So it does appear to me that the more number of cycles of treatment you give, ibrutinib plus venetoclax, 2 years in MD Anderson study, 2 to 6 years in the FLAIR study from UK, there's a better PFS, at least in cross-trial comparison. So these are the kind of the data sets, I think several of the data sets with ibrutinib plus venetoclax, which are kind of out there. And I think these are very helpful because we will see long-term follow-up of these patients eventually as these data mature, and then which will help design as well as help predict outcome for patients now that we are using second-generation BTK inhibitors and eventually non-covalent BTK inhibitors coming in the frontline setting. Let's turn to the next phase of time-limited therapy with BTK inhibitors in CLL and explore some recent developments with newer therapy options. So we talked about ibrutinib, which was the first BTK inhibitor which was approved back in 2014 for patients with CLL. But since then, we have now 2 second-generation covalent BTK inhibitors approved, namely acalabrutinib and zanubrutinib. And then we also have a non-covalent reversible BTK inhibitor approved, namely pirtobrutinib, in the context of CLL. And now studies have been conducted, and we'll review some of them, using the second-generation BTK inhibitor as well as the non-covalent BTK inhibitors in combination with venetoclax or newer BCL2 inhibitors. And some studies have also combined them with obinutuzumab, the CD20 antibody. So now let's review some of these important studies. So one of the major trials you should know about is from this past ASH meeting, which just came out in New England Journal as well, which is the AMPLIFY study. So AMPLIFY study is a registration study which has 3 different randomized arms, as you can see. These are for patients with previously untreated CLL without deletion 17p or p53 mutation. And these patients were randomized into 3 different groups. One was acalabrutinib plus venetoclax. Here, there was a lead-in of acala of 2 months, followed by venetoclax for 1 year, and then the 2 drugs continued for 1 year, so total 14 cycles of treatment. Or there was a combination arm where acala-ven with obinutuzumab, where you get 6 months of obinutuzumab starting in month 2. Or the comparator arm, control arm to say, was chemotherapy with either FCR or bendamustine rituximab, and the primary endpoint was progression-free survival of doublet of acala-ven versus chemoimmunotherapy. Now, this is the main uh, uh, PFS curve from the slide, where you can see that at 3-year data, so 36 months, the AVO, the triplet arm, had a PFS of 83%. The doublet of Acala-Ven had a PS of 76%, and FCR-BR was lower at 66%. Both AV as well as AVO arm were superior to chemoimmunotherapy arm for progression-free survival, and thus the study met the primary endpoint, which was a comparison of AV versus chemotherapy. And this is the study which we are now expect will lead to FDA approval of the combination of Acala-Ven with and without obinutuzumab. This regimen has already been added to the NCCN guidelines in February of 2025. And as I said, we are expecting approval by the FDA, hopefully soon, of this doublet as well as triplet regimen. I should say the study was not powered to assess the differences of AV versus AVO, but certainly you can look at the different arms. Adding obinutuzumab added more toxicity to the regimen, but it did appear to improve the PFS, especially for the IGHV unmutated patients. For IGHV mutated patients, AV versus AVO were very similar, but for unmutated patient, it seemed to have improved the PFS as well. So again, I think when it comes into clinical practice, we'll see how it's used by clinicians, but certainly the doublet of A plus V could be very appealing just because of 2 oral drugs together without the need for obinutuzumab, the IV infusion. So that's a very important trial. But we are having more trials which hopefully should be coming soon, which will help further define the frontline regimen. In this regard, a MAGIC trial which will test the combination of Acala-Ven, so the doublet of Acala-Ven with Ven obinutuzumab, the current de facto time-limited standard for our patients. And this is a study which has been running for a while, again for newly diagnosed patients who need treatment. And here, the treatment is for Acala-Ven. There's a 2-cycle of lead-in of Acala, then you get 1 year of doublet combination. But then at month 14, based on MRD, you can get additional 1 year of Acala plus venetoclax as well. So there is some MRD-guided therapy. Similarly, actually, for the Ven obinutuzumab arm, the standard would be to just give for 1 year. But here, just to, I guess, match the 2 arms, if you're MRD positive, you can get 12 additional cycles of venetoclax as well. So this is a very important trial in the field, and we're hoping to see those results, hopefully soon. And it will help further define which is a better time-limited approach, or I can say which is a better partner of venetoclax. Should it be a BTK inhibitor like acalabrutinib, or should it be a CD20 antibody such as obinutuzumab? And the third, I guess, the BTK inhibitor zanubrutinib has also been combined with venetoclax. This was the so-called Arm D of the frontline trial of zanubrutinib plus venetoclax. This trial enrolled about 80 patients, and this third arm was for patients with high-risk patients of 17p and p53. Again, the response rates are pretty high. And so I think this is also a very important combination, though I would say that I think the development of zanubrutinib is now more in with sonrotoclax, which is another BCL2 inhibitor, where we are waiting for the randomized phase 3 study of so-called Celestial study to be reported. Obvious next question will be, yes, can we combine, if you're combining everything with venetoclax and also sometimes with obinutuzumab, can you introduce time-limited approach with pirtobrutinib in the first-line setting, bring a non-potent BTK inhibitor in the frontline setting? And this is a trial we have been conducting at MD Anderson, which we reported at the ASH meeting last year. This is a time-limited approach of about 1 year, though again, there is a provision to get a second year of treatment for patients who have NGS MRD positive at least 10 to the power minus 5 level. These are MRD rates both in the blood and the bone marrow after 6 months of combination and after 1 year of combination. And the green highlighted green bar is patients who are NGS MRD negative at 10 to the power minus 6. So very high rates of deep remission we noted with this triple combination. And this is a study which continues to accrue, and we are monitoring patients long term. You can see on the right side, so far, with a median follow-up of about 12 months, we had not seen any progression or any deaths on the study. So you have just seen a question about how to ensure safe delivery of time-limited therapy with BTKi-venetoclax combination. So let's explore this case in more detail, but also look at some practical and safety considerations you have to be prepared for if you're going to use BTKi-ven combination in your practice. So the case you saw was a patient, Michael, has symptomatic CLL in need for treatment. Patient is currently 70 years of age, has unmutated V gene, no deletion 17p or P3 mutation, complex karyotype, and has a bulky kind of a neuropathy measuring up to 8 centimeter in size. So this patient is in need of treatment, but patient has experienced a number of travel issues because he's living in a rural location. Now, patient is interested in a time-limited approach, but he has concerns that about using IV treatment, such as IV component of treatment, such as IV infusion of obinutuzumab. So now you're exploring to see what other options we can give this patient. Now, as we discussed, there is a new option coming up of combining acalabrutinib with venetoclax, with and without obinutuzumab, but certainly you can combine acala with venetoclax together as a time-limited 1-year option. Obviously, one of the major advantages, this is an oral option, so patients can take it at home, and this decreases the number of visits to the medical center. And certainly there is no infusion if you're just using the 2 oral drugs, which prevents infusion reactions, chair time in the clinic, and so makes it a bit more easier. So now one of the questions which comes up is that how do you kind of mitigate the risk of TLS? We know that tumor lysis syndrome can happen with venetoclax, and I would also emphasize that you have to follow the guidelines, the prescribing guidelines for venetoclax, which specifically list how to categorize patients into low, medium, and high risk for tumor lysis syndrome based on absolute lymphocyte count as well as size of the largest lymph node. But what's I think very important is that when you use this combination of BTK and ven, you don't start BTK and ven together in cycle 1. So the typical way would be to start with the BTK inhibitor first, which then can be given for a variable duration of time, generally 2 to 3 cycles. So some studies have used 2 cycles. For example, the Amplify study, 2 cycles of acalabrutinib. Other studies have used 3 cycles, such as the Captivate study, the MD Anderson study. So I would say 2 to 3 cycles of BTK would be a right approach to do, and then venetoclax is added. But what is very important is that when you do this 2-3 cycles of BTK monotherapy, and in the clinical trials which have been done in this regard, when you do 2 to 3 cycles of BTK monotherapy, and then you recheck the tumor lysis risk category compared to what was baseline, as is shown in the slide here from Captivate study, you can see that the majority of patients are down-risked in terms of the tumor lysis risk. For example, in this, the blue is the high risk, which were 24% of the patients had a high risk for tumor lysis at baseline, but after you give ibrutinib for 3 months, that number dropped to only 2%. And similarly, the number of patients who were low risk increased with time, with after 3 months of ibrutinib monotherapy. And that has been shown with many other studies of these BTK combination. So that's an important point, that lead-in of BTK is important to prevent and downregulate the risk of tumor lysis syndrome. So then adding venetoclax will be easier, though you still have to follow the same guidelines for tumor lysis syndrome. But because patients will be having a lower risk, less incidence, I would say lower rate of admission to the hospital, use of IV fluids, rasburicase, and other drugs. So it makes it a bit logistically easier to administer. Now, one thing I would say in terms of adverse events is that, if you're using, and depending on the BTK inhibitor you use, for example, in the slide here, you see trials with ibrutinib combination, such as the GLOW trial on the left side and Captivate on the right side. Especially in the GLOW trial, we can see with ibrutinib-based combination, the rate of atrial fibrillation flutter was 14% of all grade, 14% all grade. The rate was lower in the Captivate study in the right side, largely, I think, in part because the patients in the captive study was a decade younger than the patients in the GLOW study. But again, if you're using ibrutinib in the practice, you have to be aware of these adverse events. And also, I would say the risk of grade 3 or 4 neutropenia, which you can see in the captive study was about 33%. But many other studies with ibrutinib plus venetoclax have shown up to 50 to 55% rate of grade 3 or 4 neutropenia, with the combination of ibrutinib plus venetoclax. Now, what about with the acalabrutinib combination? And really, one of the best examples we have is from the AMPLIFY study. And again, you can see here, if you look at any grade neutropenia, you can see that more neutropenia numerically with AVO compared to AV. Atrial fibrillation seems to be on the low rate. And again, here you're giving acalabrutinib for only 1 year duration. So again, the side effects which you see with BTK inhibitors can still occur. But I think given we're using BTK inhibitor not in a continuous fashion, long-term, just time-limited 1 year approach, I think we are going to see less of it, especially less of AFib and hypertension and others if you're going to use second-generation BTK inhibitor as opposed to ibrutinib. And lastly, just very briefly about safety experience with the study I mentioned about the PVO, pirto-ven-oben triplet combination at MD Anderson. Here we did see grade 3 or 4 neutropenia of about 60%. Many of those patients required GCSF. We also had dose reductions for both pirto and venetoclax, largely due to neutropenia, where in retrospect, probably the dose of only venetoclax had to be reduced, not pirtobrutinib. And we had 2 patients who developed atrial fibrillation in the study so far. So overall, I think same side effects we see with BTKi combinations. And it's difficult to compare cross-trial because this was a single-center study as opposed to other trials were done in a multi-center phase 3 groups. So now let's turn to a topic that will become increasingly important in the future, which is the potential for BTK retreatment after frontline upfront therapy of a time-limited approach. So as we are moving away from using hopefully continuous BTK inhibitor therapy to a situation where you're using BTK and ven combination for, let's assume, 1 year, as was true with ibrutinib plus venetoclax, which is approved ex-US, or the upcoming approval of acala-ven plus minus obinutuzumab, where again it's a time-limited approach. So there will be patients who you receive these time-limited approaches for one year or so, and after a certain time down the line, patients will have a disease progression, and that could be 2 years down the line, 3 years, 5 years down the line. So, and I think that will be a common scenario. We would note that the patients are progressing, but they're not progressing while actively on the drug, on the BTK inhibitor, but after a certain time in future. And then the question becomes, can we retreat? Are these patients still susceptible to the BTK inhibitor? Or for that matter, argument could be, are they still susceptible to venetoclax as well? And so what are the evidence we have about retreatment? And what is the potential for resistance after achieving a time-limited approach? So first, let's look at venetoclax obinutuzumab, which has been the time-limited approach to go for a while. And here in this work from German CLL study group, when patients progressed after having achieved a remission on venetoclax obinutuzumab, and then they were on a kind of a treatment-free remission for a while, and then they progressed. And when they looked at the mutations, especially for BCL2 or other kind of genes in the same pathway, none of the patients had developed an acquired mutation of these proteins, including specifically for BCL2. So you do not have resistance mutations when you're not taking the drug when you actually progress. Now, we also know that BTK mutations in the context of covalent BTK inhibitors is a very important resistance mechanism. And they're the dominant reason. Some studies have shown as high as 70 to 80% of patients will have a BTK mutation, especially cysteine 481S mutation when you progress on ibrutinib, acala, or zanubrutinib. Some studies have shown a lower incidence. But nonetheless, BTK cysteine 481S mutation is the most common resistance mutation to covalent BTK inhibitors. Therefore, if you progress on a continuous BTK inhibitor therapy, for example, patient is on ibrutinib, they progress on ibrutinib, and then you want to switch to acalabrutinib or zanubrutinib, that's not going to be an effective strategy because they would have acquired a cysteine 481S mutation, and both ibrutinib or ibrutinib, acalenzanu all work at the same target, cysteine 481S. So you really have to, in this situation, move to a non-covalent BTK inhibition or move to a different pathway, such as a BCL2 inhibition. Now, again, as I alluded to, BTK mutations as well as PLC gamma 2 mutation. PLC gamma 2 is downstream of BTK, which both of these have been described. PLC gamma 2 is actually less common. But nonetheless, as you can see, in variable number of patients, more than half of the patients on covalent BTK inhibitors will develop cysteine 481S mutations when they are progressing on ibrutinib or second generation BTK inhibitor. So then the question will be, this is continuous BTK inhibitor therapy. But what about the development of BTK resistance mutations when you're not using a continuous BTK inhibitor therapy? You're using a time-limited approach. And so let's look at this data set, which came from after the Captivate study, where we looked at patients who received the drug ibrutinib plus venetoclax as a fixed duration, 1 year duration. And then these patients progressed later. And there were 29 of those patients, on which 25 we had samples. And these patients were sequenced for BTK mutation, PLC gamma 2 mutation. And as you can see, no patient was noted to have acquired a somatic new mutation of BTK or PLC gamma 2. So basically, the argument here, or the conclusion here, is that when you had exposure to a BTK inhibitor, you stop BTK inhibitor because that was supposed to be given for a time-limited approach. Patient progresses sometime down the line. These patients will not have the resistance mutations, which you would typically see if a patient had continued BTK inhibitor and progressed while on BTK inhibitor. So the next logical question will be, if they do not have the resistance mutation, can you still go back on the same BTK inhibitor or a different BTK inhibitor, like a different covalent BTK inhibitor, and still derive benefit? And this is the data from the Captivate study, which basically says that if patients progress, again, they did not have the resistance mutations, and then retreated them, some with single agent ibrutinib, some with ibrutinib plus venetoclax together. There were 32 of these patients, and practically, most of these patients are regaining a response, with this approach again. So retreatment works, and that has been shown in some other studies of these combination therapies as well. So I think in conclusion, time-limited therapies are here to stay. So far, we had only one time-limited approach in the context of frontline CLL, which was venetoclax plus obinutuzumab. But now, I think we soon will have an FDA approval, expected to have FDA approval of acalabrutinib plus venetoclax with and without obinutuzumab as a second 1 year time-limited approach. And I think that will, have influence on how we manage patients in the frontline CLL. I think especially combination of acalabrutinib plus venetoclax may be quite appealing for physicians as well as patients, given the ease of administration of taking 2 pills, and also you don't have to take a pill forever as in a continuous BTK inhibitor. Obviously, without a CD20 antibody, it makes logistically much more easier to administer. So I think that is an important, treatment paradigm which is going to come soon in the United States for patients having two oral drugs combination for 1 year duration. I think there are trials currently happening, some very important randomized studies which are ongoing. Some have completed accrual. We're waiting for the results, including the MAGIC study. There's also a CLL17 trial, which is comparing ibrutinib with the venetoclax obinutuzumab and with ibrutinib plus venetoclax. So kind of a continuous therapy versus standard approach, which is a very important trial as well from German CLL study group, which we're waiting for the results. And we hope to hear soon as well. And there are many other randomized trials ongoing, which will further kind of refine the frontline therapy approach for patients with CLL. And I think the important thing is that when you treat with these time-limited approaches for our patients, I think you will not develop resistance mutation when these patients progress later. You have the ability to retreat these patients. And also, as we discussed in one of the cases, when you debulk these patients by 2 or 3 cycles of a lead-in BTK inhibitor, and then you add venetoclax, you will have much easier initiation of venetoclax because most of these patients would have been adequately debulked, and you can use venetoclax without much risk of tumor lysis syndrome. So with this, we'll conclude. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. To access all materials for this activity, visit peerview.com/RMQ860.